This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs. Also, make sure to check out and subscribe to our YouTube original channel, UCTV Prime, available only on YouTube.
Welcome, everybody. My name is Karen Sun. I am one of the pediatric hospitalists here at UCSF and a course chair for this mini med school session. And I think we've got a really good program set up for everybody with a variety of different health topics surrounding kids and kids in our community. Tonight, I have the great pleasure of introducing Dr. Lawrence Chang. He is an assistant adjunctive professor here at UCSF. And he's the director of our pediatric allergy clinic at UCSF Benioff Children's Hospital. He got his PhD in immunology and his MD at the University of Washington in Seattle. And he's currently one of the members of our Department of Pediatrics. So I'd like to welcome Dr. Chang. Thank you, guys.
Good evening, everyone. Thanks for coming. And I know we're kicking off this series in terms of the pediatrics tonight. And so we're going to actually have all the questions at the end. But feel free to jot them down. And if you have questions along the way, just jot them down. Hopefully you have a syllabus or something to write on. And we'll get them at the end. There should be plenty of time for questions at the end. Okay? All righty. So today, food allergies are becoming a bigger and bigger issue amongst children today. And so what I thought I'd do today for the talk portion is just take you through all three aspects: the past of allergy as a field, where we are today, and where we hope to go in the future, and how UCSF is going to be a part of that. So just to give you a sense of food allergies and allergies in general, or really just food allergies, I got this slide from the CDC, and what it highlights is the fact that food allergies are pretty common. This is a percent of all children from 0 to 18 years of age who have some form of food allergy right now, and it's 4%. And while that might not seem like that much, that's one kid in every classroom in San Francisco. And so as you increase the number of classrooms at various schools, that number just increases more and more. It's really, really quite common. And sometimes, of course, food allergies can be quite serious in terms of the effects they have on the children. And we'll get into that a little bit more. Just some other facts as well. There's 100,000 emergency department visits every year due to food allergy alone. And unfortunately, about 150 to 200 deaths, both adults and children, result from that. But what's interesting is in the last 10 years, and some of you may have personal experience with this, in the last 10 to 15 years, we've seen that the rates of food allergy have increased by almost 20% amongst kids in just this very, very short amount of time. While some of that may be due to better vigilance and testing and diagnosis, it is still a pretty rapid rise in a single disease. Children with food allergy are 2 to 4 times more likely to have other related conditions such as asthma or allergic rhinitis. And in fact, when you put all three of those diseases together, nasal issues, lung issues, food allergy, and skin, almost 20% of children have at least one of those conditions. So this is a very, very common disorder. And so just as a show of hands, how many people in this room personally suffer from allergies? Okay, or how many people know someone who suffers from allergies? So we got about 100% there. And so I think it's pretty clear. This is a very, very important disease. Okay, so today's talk, what are we going to cover? Which, as I said at the beginning, we're going to go through the history of allergic reactions in the field of allergy, where we are today, emerging therapies, and how do we make things even better and do even a better job for our children. So I think one of the things that's interesting about allergy is that it's a little bit confusing. Sometimes it's not always clear what you're allergic to. Sometimes it's not clear whether you're allergic at all. And that is something that really started at the beginning of allergies. And so, actually, before I get there, sorry, this screen doesn't have my next slide. I just want to tell you, I already talked a little bit about this, but what are allergies? And so, just to remind you that we have conditions such as asthma and rhinitis that affect the respiratory tract, the lower respiratory tract and the upper respiratory tract. And then we have food allergies that can affect the various parts of the intestine, as well as anaphylaxis, which is, of course, the most profound and I think most the one condition that sort of is most brings up the most attention, just because of the way it can affect children so quickly. And then there's eczema as well as a skin condition. And so what I was trying to say before is that, again, although when we see these things, we think we know allergy when we see it, but in fact, it can be confusing, and that really dates back to the beginning of allergy. And so this is, again, we're going through the history, so this is way back in time. This is King Menes. He's the first pharaoh of Egypt, and he was a very powerful figure that we'll get to in a second. But the way he died was quite controversial. He may have died from a wasp sting, a dog biting him, a crocodile, or a hippo. No one's quite sure exactly how he died. But somewhere along the way, somebody thought that it was the wasp. And it was because of this, I believe this was on his sarcophagus. I may not be absolutely certain about that. But there were these hieroglyphs on his coffin. And there was this little barb that people thought was indicative of the fact that he had been stung by a wasp and died. And so it became part of allergy that perhaps this was the first documented case of allergy. But the story goes on. He may not have ever existed. He actually might, can one man actually invent papyrus, start irrigation in Egypt, unify the country, and conquer all foreign lands? That'd be quite a task. And so he actually really is more mythologic, and is probably a confluence and a sort of a composite of various leaders of Egypt at the time. But the allergists really thought that it was from a wasp, but later on it was thought that this was actually just an inadvertent scratch on the sarcophagus, and that he probably died of some other cause that's just not well laid out. But things do get a little bit better in terms of allergies, so we do get some improved scientific reporting. So Dr. Debré in 1765 described in a French journal how a patient had been stung by a bee near the eyebrow and unfortunately passed away. About 70 years later, François Magendie, also French, had noticed that if he took rabbits and injected them with hen's egg, that they would actually often have very severe reactions after the second or third dose. And he attributed this to toxins in animals. And so again, he thought that somehow that these injections were actually liberating some kind of bad humor or toxin that was killing the animals. And Dr. Jenner, who had already done work on vaccination, some of you may be familiar with his work, which was the fact that he could take cowpox and vaccinate people, and so they would actually be protected. And he hypothesized that the body was actually responding to that vaccination and then allowing for protection against the virus in question. And so we get to basically the start of allergy. So we have at this time, at the turn of the 20th century, we have this sense that the body can recognize foreign substances, and that really, though, the main idea was that the body would recognize these substances things that could potentially be harmful, and then make a protective response, this idea that Jenner put forth about vaccination. And so that was kind of where immunology, the idea of how the body would fight off infection, was born. But no one had really thought that maybe the immune system or the body's response to things in the environment could actually be counterproductive. And so this is how, that's how allergy came about. And this is what I'm about to tell you now is the story of how people started to understand that the body could actually do things, could respond to things in the environment that in ways that were actually harmful. So this is a Portuguese man-o-war. And it was named as such by 17th century sailors who thought it looked like a Portuguese man-o-war, the actual ship. And I personally am not sure about the resemblance, but there does appear to be a sail here. Hopefully there's no keel that looks like this on this ship, although that's cut off here. This is not a jellyfish. This is what's known as a siphonophore. So it's a colonial organism. It's actually sort of an organism. It's a community of organisms that come together to make this larger structure, each with its own job. Some are in the sail, and some are in these tentacles that are actually responsible for gathering food and processing and digesting it. And so sailors noticed that when they got caught up in these tentacles, they'd get very, very painful stings. And though they didn't have deadly reactions, they certainly knew well enough to stay away. And so this is a picture of what it looks like to come into contact with one of these. You can just see how incredibly profound these reactions are, and I can only imagine how painful it is. And some of you may recognize this woman. This is Diana Nyad. I don't know if anyone whether any of you know who she is. She's a radio personality in Los Angeles, and so she's been in the news the last few years. She's been trying to swim from Cuba to Florida in open ocean without any protection, really. And so these stings are in part what stopped her. She got caught up in this man-o-war, and now you can really see and understand why it would be so difficult to do that swim if you got those on your arms. So it's an incredible feat that she's trying to accomplish. Okay, so that was a bit of a digression. So we have this sense that you have this. So essentially. Again, in the 1800s, right at the turn of the century, people were trying to understand whether or not things that cause these bad reactions, whether or not you could actually have folks be protected against them if you expose them to small amounts of it early. Again, this idea of vaccination, that the body can protect against things in the environment so long as it's seen it in the right context. And so this is Prince Albert of Monaco. And he was he's a cosmopolitan, a Renaissance man. He was not only in line to be for the throne for Monaco, he also had a great deal of interest in science. And in a real interest in this Portuguese man-o-war, he thought that the reason people got these terrible stings was that there must be a toxin. He hypothesized that there must be something in those tentacles that was causing these reactions. And what he hoped was that, again, if he could find out what that toxin was, he could prophylax or vaccinate people against it such that they could come into contact with it later and not have any ill effects. But, like any good monarch, he thought, well, maybe I ought to just recruit some folks to help me out with that. But so he actually, you can imagine this as scientists. You're hanging out in your lab in Paris, and you get a call from the Prince of Monaco, and I'm sure this was a tough sell. He said, you know what, this summer I'd like to take you on my yacht, the Princess, I think Princess Marguerite. And I might have the name wrong. But basically, I would like to take you on my yacht, sail to the Mediterranean, and collect these Portuguese man-o-war and try to do this scientific project. I'm pretty sure for me, it wouldn't take much to twist my arm to go on that expedition. Oh, it's the Princess Alice, sorry. So they set off in July of 1901, and after what I'm sure, so first they knew, so Richet and Portier, so this is Charles Richet and Paul Portier, and so these are the two scientists that the prince must have twisted arms to get to go with them. And they were smart. They knew that to test for the presence of the toxin, they needed some small animals that they'd be able to test on. And so they took some pigeons, ducks, and frogs with them. They loaded them on their yacht, and after what I'm sure was an arduous couple of months sailing the sea and enjoying the sun, they actually did come upon a large colony in the Mediterranean. And so they collected these Portuguese man-o-war. They were able to isolate the toxin. They were able to concentrate it, and they started to inject it in different fractions of their isolates into these different animals. And indeed, they were able to induce toxic reactions in these animals. And so they termed the name hypnotoxin for the effects that this toxin had on the animals. So they went back to Monaco in 1901, and then after that, Richer and Portier decided to go ahead and look into prophylaxis strategies. And so, unfortunately, there's not much Portuguese man-o-war near Paris. So Richer and Portier were really smart, and they went ahead and went to the colder coast near Paris and actually found sea anemones and purified toxin from them. That had already been described, and they had noticed that the effects were very similar. So they hypothesized that it was probably a very similar toxin. And so what was interesting, though, is they purified the toxin on their small animals. They were able to demonstrate the same effects, and they decided to use their own dogs, Galatée and Neptune, as the test beds. And so they actually injected small amounts of this toxin into their own dogs. And unfortunately, on the second vaccination, the animals died within 30 minutes of respiratory distress, and they were essentially foaming at the mouth from all the fluid, from the allergic reaction that they had not quite understood. But what they realized was this: they did a lot of other experiments, and quickly realized that instead of making a reaction that was protective, this was actually a harmful reaction. And so instead of prophylaxis, it was what's known as aphylaxis, not helpful and not protective. But being French, they said, you know what, that doesn't sound good. Aphylaxis, that just does not sound good. It was not euphonic. So they coined the term anaphylaxis. And so that's how we have the name today. Okay, so this was really exciting work, because what it said was that basically the body could respond to environmental stimuli and have harmful effects. So they actually, Richer, the more senior of the two, was awarded the Nobel Prize in 1913. And Portier, although he did a lot of the work as well, for a number of reasons, just wasn't awarded, didn't share this prize. But Richer and Portier remained lifelong friends. And so from there, they are actually all three. Yeah, so Portier may not have gotten the Nobel Prize, but he did get a stamp. So this is a stamp from Monaco that commemorates the Richer and Portier, and of course the prince gets top billing. And but this is the Portuguese man-o-war. So this is a pretty neat stamp. Okay, and so from here, essentially, the field moved forward very quickly. People were, maybe not that quickly, about 50 years later, the Ishizakas, a Japanese couple who were studying allergy, were able to isolate this antibody, this molecule that the body makes to cause allergy. The E of IgE actually stands for erythema, not allergy or something like that. It actually means immunoglobulin for redness, or immunoglobulin or antibody for redness. And so I don't want to get too technical. We can talk about those things later. But essentially, the idea was that our bodies were making a response that was driving the allergy. And it was later found that there are certain cells in the body called mast cells as well as basophils that could bind these molecules and then cause the profound reactions that we see in acute allergy. Okay. So, I'm sure that people have done this many times, but it's time for a test. You're in medical school, so we have to do our test. I hope none of you have looked through the syllabus, because if you have, then I neglected to take these out of the syllabus before you were given them. So try to answer with how you would have thought. Okay, so this is from 2012. Okay, so if you had so we're not talking about food allergy, but let's say maybe you ate a peanut and you have a very sudden bad reaction. So in an acute asthma attack, which of the following would you take? A, oral albuterol. B, 2 puffs of albuterol from your inhaler, acetaminophen or Tylenol, ibuprofen or Motrin, and then, or would you go outside and smoke a cigarette? So may I see a show of hands for A? You can all have to raise your hand. Who wants A? Okay. B, 2 puffs of albuterol. Almost everyone. C, acetaminophen, ibuprofen, go outside and smoke a cigarette. There you go. I like that. As any good test taker would know, when there's 2 of the same answer, it's probably one of those 2. So indeed, the answer is take your albuterol. And there are various forms of it now, but these are all bronchodilators, and they help to open the airways acutely. Okay, so now put on your bowler hat, if you're a man. My fashion in terms of the 1912s is not as strong for the ladies in the audience. But basically, now we go back 100 years, a little bit of a different question. So, what is the most effective therapy for an acute asthma attack at night? What are you going to do? Are you A, you're going to go outside and breathe in the cool evening air? B, boil a pot of water and breathe in the steam? C, take some Zoagriane. I have a picture of it here. Clearly, it's... No, look, asthma conqueror. D, go outside and smoke a cigarette. Okay. So who votes for A? Go outside and breathe in the cool evening air. Perfect. We got 1 taker. Salute the courage. Boil a pot of water and breathe in the steam. Yeah, there are a few more takers. Excellent. Take some Zoagriane. Asthma conqueror. D, go outside and smoke a cigarette. Ah, thank you. So of course the answer is go outside and smoke a cigarette. You guys probably figured that out. So this, it's very interesting. Although, we always, of course, in today's society, we're going to associate smoke with worsening of asthma, right? That's all we hear about. And of course, that is all true. But the difference is that here we have cigarettes that have, that are derived from this plant called Datura stramonium, also known as Jimson weed. And it actually has a compound known as an alkaloid that is the precursor to modern-day drugs that actually help to open the airways that include Atrovent or ipratropium bromide and Spiriva, which is titotropium. Okay? So I wanted to just read you, I'd go back a slide and just read you something about one of these, this cigars de joy. They give immediate relief, and actually might not be too far from the truth, in case of asthma, cough, bronchitis, hay fever, influenza, and shortness of breath. Pretty much anything from the upper airway to the lower. So this was from an ad in a newspaper. One of these cigarettes give immediate relief in the worst attack of asthma, cough, bronchitis, hay fever, and shortness of breath. Persons who suffer at night with coughing, phlegm, and short breath find them invaluable as they instantly check the spasm, promote sleep, and allow the patient to pass a good night. Are perfectly harmless and may be smoked by ladies, children, and most delicate patients. In boxes of 35 cigarettes for, looks like, 2 cents. From Wilcox and Company. Caution, to guard against fraudulent imitations, see that each box bears the name of Wilcox and Company, 239 Oxford Street, London. So this was from 1886. It's just interesting, these things that you can dig up. I thought that was really interesting. Okay, so enough of the history. Where are we today? Okay, so what is our understanding of allergy today? And I just bring up this slide again just to show you the different manifestations of allergy. We're going to focus on food allergy, but I want to, in the end, I'm going to talk a bit about food allergy, but this is really a bit more broad and just talking about allergies in general and how and why they're becoming more prevalent. So I think that the key, last year I actually gave a lecture. It was a half of a lecture, and you're welcome to look at that for more information. But I really focused on the clinical expression of allergy and how it's quite variable. And we're going to talk a little bit about that because I think it's important to understand that as we move forward, that allergy is not just one thing. It's not just a sneeze. It's not just asthma. It's not just anaphylaxis. It's a little bit more complicated than that. And we're only now teasing that apart. And I think as we tease that apart, we'll understand that this is a little bit more broad, and the way we treat it needs to be accordingly addressing the pieces that go wrong. Okay, so what drives allergy? Well, a simple view of allergy, and I think the view of allergy that we most have is that, well, if you have an allergy, take an antihistamine. And so where did that come from? Why do we have that view? Well, I talked a little bit about this cell called the mast cell. These cells live in the tissue. They live in your skin, your nasal tract, your lungs, and in your gastrointestinal tract. And so they have these receptors, which are just molecules that can bind to other molecules. And one of the molecules that mast cells have is what's called the IgE receptor. And so it binds IgE. And so as we've been kind of referring to, IgE is an antibody. Usually antibodies, again, are protective in the way that we think about them. But in this case, for IgE, it can bind to mast cells. And in the wrong setting, in the case of allergy, if you come across a peanut, a cat, a dust mite, or perhaps, this is actually funny, I'm not sure who would want a stuffed animal dust mite, but that's what this is. So not only does it remind you of this awful looking insect, it also harbors dust. So what happens is when you come into contact with these allergens activate the mast cell, and they release these granules that are held inside the mast cell. And these granules contain a lot of chemicals, including histamine. And so that's why you get the wheal and flare, or the sneezing, or the sudden amounts of large, copious drainage from your nose. So that is the basic view of allergy. And I think that that's the view of allergy when we think of allergy, reach for the antihistamine, because this process is occurring, and we need to stop it in its tracks by using that class of medications. And so allergies are actually a lot more complicated than that, though. You can't take a mast cell-centric view. There are a lot of different cells that interact, and they interact in innumerable ways. These are just some cartoonish lines to tell you that this is really a larger part of a network that, depending on the module or cells that are engaged, will lead to a specific clinical outcome. So for hives, for anaphylaxis, yes, mast cells are a critical mediator of that. But for things like eczema, where we have a chronic dermatitis, particularly seen in children, or asthma, where we can have chronic conditions where asthma leads to chronic obstruction of the airways and difficulty breathing, those involve different cell types. And so so the limitation we have in allergy today, which was a large part of what I talked about last year, is that all of our testing and our ability right now to diagnose allergy hinges on this IgE molecule, but does not adequately address the rest of this program. And I would argue that a lot of these cells, this part of the allergy program, is really probably what's driving a lot of this. And that's what we really need. If we want to move forward, we really need to start learning. We need to start to learn how to address these issues, be able to diagnose which ones are active, and be able to interfere with their function. Okay. So, allergy, is it all bad? Is there something good that we can glean from it? I'm sure that for those of you who suffer from allergy, you're not going to be feeling real good about these cells. But they do serve a purpose. And unfortunately, that purpose hasn't been as clear as we'd like. But they're part of the immune system. And as we all know, the immune system is really there to fight off infections. And so what's clear is that this program of cells clearly is important for fighting off parasitic infections. So this is a worm that I believe it's a hookworm, and of course something that is not really found in the United States much at all, except for those who travel. But they'll live in your GI tract and can cause a number of symptoms. But those in the third world are colonized with these. But beyond infection, new theories are evolving that suggest that perhaps the allergic immune system is really important for repair. That when you have a cut, you have a break in your skin for whatever reason, that part of the immune system comes as this little boy is doing, running into the area of damage, trying to find a way to repair it. Because the best offense is good defense, and so the best thing to do if you don't want to get infected is to make sure your barriers are working well, so that things don't get through. And also other, some insects like mosquitoes, of course, they can penetrate our skin and they like to feed off of our blood. And so it may be that this part of the immune system was important to help alert us to the fact that there's something on us and that we want to scratch that off as quickly as possible. So mosquitoes, ticks, all those sorts of things. So those are the theories. I think it's clear that parasitic immunity absolutely requires this allergic immune response, but some of these other aspects were still being worked on. Okay. So one of the clear things from clinical data is that allergies are really a developed world disease. And so this is taken from a study for asthma. I don't have as much data for food allergy. It's a little bit newer, but asthma has a very robust history of clinical research. And what you can notice is that in red here, these are developed countries, that the proportion of the population having asthma is greater than 10%. And you can see that the United States, Canada, Brazil, Australia, New Zealand, and the United Kingdom, all developed countries, all have very high rates of asthma. And you can see that less developed countries, Russia, China, other areas of Southeast Asia, much lower levels of much lower prevalence of asthma. And so when people have been trying to ask the question, what is driving allergy today? I think one of the first and foremost pieces that has been informing us or driving people's thinking is the fact that there's something about modern living, there's something about the developed world that has led us to the high prevalence of allergy and food allergies today. So what is behind the rise of allergies? So I'm going to talk to you today about 3 concepts of what people are thinking might be driving or are participating in the increases in allergies that we see today. So we're going to talk about what's known as the hygiene hypothesis. Just out of curiosity, how many of you have heard of that? Okay, it's about half of the folks in the room. Vitamin D exposure or lack of, and timing of food introduction for babies. Okay, so what is the hygiene hypothesis? Though many of you have heard of it, it's actually been around for more than 20 years. Dr. David Strahan, who was an epidemiologist in the United Kingdom, he had noticed even back then that there was a large increase in hay fever, allergic rhinitis, in patients in the United Kingdom that he took care of. So he took an epidemiologic approach to understanding the underpinnings of allergy. He took 17,000 children who were born in a single week in 1958 in the United Kingdom, and he interviewed them that many years later to see if they had allergic nasal disease. And then he looked at a number of demographic parameters to try and see if he could crunch those parameters and see if one of them fell out as driving or being associated with increased rates of allergy. And so what he found was that those who had come from smaller families were more likely to need lots of Kleenex, and those with larger families were less likely to need lots of Kleenex. And so he hypothesized that this was an effect of exposure to childhood infections. And thus, the hygiene hypothesis was born. And so how has it evolved since then? And it really has evolved quite a bit. And I think that one of the things that we've learned is that what infections and exposures are good. It's not all of them. So this is actually a picture of rhinovirus, the cause of the common cold. Again, another stuffed animal to portray these. It's interesting what people come up with. But what's been noticed is that in viral infections in childhood, like rhinovirus, like respiratory syncytial virus, also known as RSV, are associated with increased rates of hay fever. And even if you came from a larger family, but if you came from a smaller family but were exposed to dogs, cats, or farm animals, you seem to do a lot better. And so that is been a very strong data to suggest that there are only certain types of infections or exposures that are quote unquote good for us, at least from the perspective of decreasing allergy. So this is a picture of a Bavarian family. This is not quite a 1-month-old, but even at the age of 1 month, after these mothers who work on the farm have had babies right there by their side all day long, right amongst right in the feed, right in the manure, right there. All of those exposures are occurring, and these babies, their health and infectious rates, I think, are no higher. But what is clear is that they have very low risk for allergies and asthma, much lower. And this is been a lot of work. It's interesting, even people who live in the same area, but one's a farmer and one's not in Bavaria, those folks who live on the farm, their kids are protected. Those who aren't are not protected. So there's something very clear about this exposure that protects kids from allergy. Okay, so clearly the take-home points must be we must all move to a farm with pigs and cattle, hopefully. It's amazing, actually. These two animals in particular have been associated with decreased allergy. Have lots of children. Get a dog instead of a child, potentially, and let your newborn play in the dirt. And so I'll share a personal note. So when my youngest child was born, you put the baby in the bassinet after you are moving from the labor and delivery room to the the room that you're going to stay in. And so I had, I'm not sure if I was wearing sandals or something like that, but I had some shoes. Shoes from one of my other children. So I put it underneath the bassinet, so at least a foot away from my newborn baby. But the nurse she did not like that. And so she chewed me out to say, how could you expose your child like that? And so it's interesting because it brings home that point is, should we then smear our children with, cow manure? I think not. Medicine has come a long way in 150 years. These are mortality, this is lifespan from 1850 to 2000. You can see that in the last 150 years, the lifespan has almost doubled for men and has doubled for women. And so likewise, the total looks like that. And the infant mortality, which was 1 in 5 children just 150, 160 years ago, has now gone to much lower levels, although certainly still there's still work to be done. And so I think what's becoming clear is that is not so much globally your exposures, but what we're probably going to find, and I think that and this is really where the field is headed, is to try to understand what is protective. Are there signatures of protection? Are there specific bacterial subtypes that are protective? And so a lot of this work collectively is you may hear this term called the microbiome. So the microbiome is where people are trying to study what all of the different types of bacteria that are in our various, that are in this case, the gastrointestinal tract, and trying to correlate that with specific outcomes for food allergy, and specifically, is there that one bacteria that we could take, that one bacteria that's not harmful, that doesn't cause infection, but is absolutely protective and changes the way the immune system interacts with the environment, such that allergies are not the problem. And that's really kind of the Holy Grail, and we may get there. We'll have to see. I think that we'll see within the next decade or so. So what about vitamin D? So vitamin D is a vitamin, of course. It's a fat-soluble vitamin that we can actually make ourselves in our body, and we can also consume it from various dietary sources when they've been supplemented. But through your skin, when you're exposed to UV light, your body's actually able to produce this particular vitamin. So we probably think most of vitamin D for its effects on bone health and its importance on maintaining strong bones. That's why all of our milk that at least is pasteurized and put through more that's processed is supplemented with vitamin D in order for us to actually better to make sure that we have enough to really build those strong bones. But vitamin D has a very interesting history as as a potential immunomodulator. That is, a vitamin that is very important for immunity. So some of you are wondering, what is this picture of? So this is actually a sanatorium from about 100 years ago. So this is at a time when tuberculosis ravaged a lot of children. It was called the consumption in certain parts of the world. And so what was interesting is that it was noticed that people who lived at high altitudes, that was exposed to the sun, seemed to do better with tuberculosis. And so it was that entire sanatoria were built, and these are actually children, so that they could sunbathe. And nobody knew, of course, that vitamin D was being made, but this is something, looking back, that we really think may have been the reason that these kids did better. And so what about vitamin D today? And so lately, people have wondered, again, going back to our initial question, what is it about modern living? What is it that's different about the developed world that seems to predispose to allergy? And so vitamin D has been one of the questions that people have been looking at because of the fact that, again, it has some effect on the immune system. It's not absolutely clear what that effect is, but there's something that it can do to alter the way the immune system behaves and its function. And so people, of course, then, in terms of vitamin D, what's interesting is that allergies rise has coincided with two societal changes that both, but in different ways, affect vitamin D levels in our body. So the rise of allergies coincided with vitamin D supplementation for bone health, but it has also coincided with the increased use of sunscreen to prevent skin cancer. So, living in San Francisco, of course, you probably really never need sunscreen, and you still are going to be vitamin D deficient if you don't drink enough milk, just based on that. But it's been so the question has been, what is vitamin D doing? Is it making food allergy worse, or allergies in general worse because we've been supplementing, or is it actually the fact that it's missing in a lot of people the reason that we're getting a lot more food allergy? And I think that the latter is probably going to be more likely the case, if at all. And one of the really interesting ways to look at this, so there are a number of studies that can look at supplementation, and you can get various, and they can be very well done. I don't mean to imply that they're not, but there can be so many variables that make it difficult to make really strong conclusions. But one paper from this group noted here that I found really interesting, it was from about 6 years ago, was the fact that you just kind of let things fall out, and you look at this question: how prevalent is epinephrine, our epinephrine prescriptions? That's what we're looking at, epinephrine prescriptions at various latitudes within the United States. And what was interesting was that people who were from lower latitudes, the southern states, presumably sunnier, actually had quite a bit less EpiPen prescriptions per person than those from more northern states, those who would have less sunlight and potentially have less vitamin D to begin with. So these data have been used to start to look at this question of whether vitamin D has some sort of a anti-allergic effect, and that because of loss of vitamin D, because we were less in the sunshine, or don't drink quite enough milk, or just in general are vitamin D deficient, because of those things, is that the reason that we're having increased allergy? The jury's out, but I wanted to put it out there because this is, again, coming back to this question of something that, something that's been changing in society that might be leading to the issues that we see with allergy today. I wanted to spend a little bit more time talking about food introduction, and this is at the turn of the 21st century, not the 20th century. And so, I talked a little bit earlier about how in the last even 20 years, we've seen these very rapid increases, up to 20% in the prevalence of allergy. And we certainly hope that doesn't increase at that rate, but if it did, we could see even larger burdens of food allergy for patients today. But if we go back about 15 years, I think one of the things that becomes clear is that the way that children and the dietary guidelines for food introduction really changed right around that time. So in the year 2000, the American Academy of Pediatrics came out with this policy statement talking about how to introduce foods for children. And the key take-home points were this. If you could, try to breastfeed exclusively. And if you were a family who had a history of food allergy, you should jump right to a hypoallergenic formula for supplementation if need be. If a mother had a history of food allergy, she should restrict dairy, egg, fish, tree nuts, and peanuts from her diet during pregnancy, as that would likely stave off further allergy in her child. If you were, if you were at risk, you could, instead of hypoallergenic formula, I don't know how many of you have tried it, it's not terribly palatable. You could also try soy formula instead of cow's milk formula for at-risk children. No solid foods whatsoever until 6 months of age. Introduce dairy at 1 year, eggs at 2 years, peanuts, nuts, seafood at 3 years. And this is, again, not for safety reason, but because you probably wouldn't want to give a peanut to a 12-month-old just because it's pretty hard to swallow. It might get stuck in the airway. But peanut butter is certainly something you could give to a 12-month-old. But no, this was to no exposures until 3 years of age. And it was developed by dietitians with nutrition as a primary goal in mind, although they definitely wanted to keep in mind food allergies as well. And the thought would be that, well, if you simply avoid foods that could be allergenic, you would not become allergic. Well, what happened? Well, rates of food allergy increased. I'm not saying it's causative, but that correlates in time. So again, it may be coincidence. But what was interesting is that when people actually tried to study questions of maternal restriction in pregnancy or restriction for children, they found that rates of food allergy were really no different. Once they got exposed to the foods that were allergenic, whether they were exposed before or not, they were getting allergies. And so people really started to wonder what was going on here. And during the last decade, in the 2000s, another interesting story came out that really kind of helped to push us in terms of thinking about whether or not this sort of approach to food introduction is the right one. And so this is a peanut snack in Israel called bamba. So it's been said that the first two words that a baby in Israel knows are mama and bamba, because this is I call it a peanut Cheeto. It's like an air-puffed peanut. And so I don't know how many of you have young children or have seen young children today. A lot of kids today have these veggie puffs, these things that they don't need to chew. They can just put in their mouth and it basically melts. Well, this is a peanut-derived version of that. And so even as young as 3 or 4 months of age, kids in Israel were getting bamba. And this is a little bigger picture. It looks like a Cheeto, but I've not had any of these. But you can apparently get a 24-pack on Amazon. If you wish, and they are sold in San Francisco now. But when I started, I don't think that they were very easy to find, but they're becoming easier and easier to find in the city. So what was interesting was that again out of the UK, a physician there had noticed that though the children in the United Kingdom of Israeli descent were genetically similar in the UK and Israel, the rates of peanut allergy were completely different, with very low rates in Israel, but higher rates in the UK. And the kids in Israel, it wasn't as if they couldn't develop food allergies. They did develop food allergies to tree nuts, to sesame seeds, just not to peanut. So he began to ask the question, is it timing of introduction? And also, was it specific to the food exposure? And so there are studies ongoing right now in London. It's by this gentleman named Gideon Lack. And I think that it's going to be wonderful data that are going to be coming out to look to see if asking this question prospectively, kids who are exposed or not exposed, is there a difference in the outcome of their peanut allergy? And so that'll come out soon. And I think things like this will go a long way toward informing us on how to move forward in terms of food introduction. And so it's interesting how this evolves so quickly. So I showed you this in 2000, that those were the recommendations. 8 years later, the same academy said, you know what? That might not have been entirely accurate. So they sort of just pulled back and said, well, most all of those guidelines were gone. Breastfeed as long as you can. If you're have a strong family history of allergy and are at risk, you know what? It's not helpful to avoid, and it's not harmful either. So there's just basically no guidance, but you don't need to avoid. And in 2010, a landmark event in food allergy occurred, which was that the NIH, the National Institutes of Health, came out with a guideline for the diagnosis and management of food allergy in the United States. And this is wonderful because it helps to, and this was somewhat of what I was talking about last year, which is it helps to really pull together what food allergy, how to diagnose it, what are the limitations of the tests that we have, and how to approach food introduction and food testing in general. And so things have changed a lot, and this is only in 10 years. And I can only imagine what 2020 will look like. It'll be very interesting because so much work is being done and has already been done to try and make changes for the future. So one last piece that is what's interesting to think about is so you might ask, well, why does it matter when you introduce? Is it a matter of timing of the introduction that is going to define when and if someone's going to have a problem with an allergy? There's lots of foods that we all, as adults, try for the first time, and generally speaking, I hope, we don't develop a food allergy right away. So I think what it may be is that really in the developing immune system, the skin may additionally be a very important piece. So this is a poor baby, a cartoon from this article here with the rash of eczema. And so it may be that partly the reason why we don't want to delay food allergen intake is because if you get an exposure through your skin, you're more likely to make allergy. But if you can get some of these exposures early on in life, and again, not saying that we should be feeding our 2-day-old peanut butter, but if somehow the initial way that kids are being exposed to these food allergens is through their gut, they're more likely to develop what's called tolerance, or the ability to eat the food without having a reaction. Okay, so what about treatment today? So again, we have our rubric of different allergic diseases. And treatments today really are geared toward the end effects. We have antihistamines, we have bronchodilators. We don't have great targeted therapy to really be able to come after this, but I'll get a little bit more into that in a second. But it's interesting to think about that really all the drugs that I prescribe or your doctor prescribes are really 30 to 50 years old. We don't really have many new tools to use. So what's on the horizon? Well, one interesting set of studies coming out of Mount Sinai is from Herbal Remedies, Chinese herbal medicines, and so this is these are not the ingredients, but it's I believe a concoction of 9 different Chinese herbal medicines, at least in mice. So it's a little bit of ways from humans, though it's getting there. Appears to interfere with allergy once it's started, and so it may be that this is one area that you'll be hearing about in the upcoming few years as a way that we might better be able to treat allergies. You know, I talked about earlier about that Jimson weed, right? There's so many compounds in nature that if we could just find a way to either combinatorially understand what combinations work well to cause an effect that we're looking for. So these are just really amazing and interesting studies that I think we'll be hearing more of about in the next few years. Again, I just want to give you a broad overview of things that are going on. But one thing that I want to talk a bit about was this idea of oral immunotherapy for food allergies. So some of you may have heard of this idea that you feed children with food allergy small amounts of the food that they're reactive to, so that eventually they'll actually be able to tolerate the food and eat it. And so this is akin to what we do with something called allergy shots, which you get for allergic rhinitis, for instance, and where patients come in once a week for a time and then once a month, and they get exposed to the allergen dust or dog or cat, such that their bodies will be retrained and they'll be able to tolerate exposures to those allergens. Well, the same idea has been explored for foods, and it seems like the early data, these really been taking off in the last, I'd say, 6 years or so. And the data are very promising that you can get children who were extraordinarily food allergic, if you expose them to small amounts of the food, to be able to get them to eat serving-size quantities of the food allergen. But the problem is that it becomes a medicine, and it's something that they need to take essentially lifelong. Otherwise, for I'd say at least half the kids for things like peanut or milk, they go right back to square one if they stop taking them to drugs. So it's not truly what we'd like is for someone to not have to eat peanut butter every day, just to be able to eat it when they want to. But it's something that's very interesting and has shown a lot of promise. But even though it's very promising, it's something that pretty much anyone could do. Our main association, the Quad AI, actually published a paper to say that this was not ready for prime time. And so even though there are a lot of good outcomes that are being derived from this, we're going to go a long way toward seeing this in the clinic every day. Oh, so this was actually, sorry, this was showing that this was helpful, and this was the follow-up to say it's just not ready for prime time. But I think what we really, I kind of alluded to this at the beginning of the talk, which was the fact that when we think about allergies and the way they manifest, right now, so these are all of our cells of interest, those that cause allergy, and these are some of the molecules that these cells spit out or secrete to cause the effects that we see as clinical allergy. So ideally, right now all we really have is antihistamines, and we can block leukotrienes. But ideally, what we'd really like to know is not so much what parts of this pathway we can block. What we'd really like to know is, well, if that in instance in this, are there signatures? Are there ways are there tests that we could perform that would allow us to say, okay, in this situation you have asthma, that these cytokines, these chemicals that the body makes to organize and drive an immune response are in play, and therefore this is what you want to target. Or is it more of a different flavor of allergy in which this class of molecules, these red molecules, are the ones that we need to work on? And so the goal of I think a lot of research, we're about to get to the future, is to try to understand signatures of allergy, signatures that help us differentiate one patient from another so that we can have better and more targeted therapies. Okay, so this idea of having signatures, being able to define these signatures, and then intervening based on them is something called a biomarker. So what are biomarkers? Well, biomarkers essentially do exactly what I said, which is to try and define something that we call allergy. And again, we know this in a broad sense. We know that in general, allergy could involve any one of these 7 different parts of the immune system. But if we could fine-tune it and drill a little deeper and be able to target our therapies to only those bad actors, then we'll potentially be more successful. And that's what biomarkers are. So I think that if I asked anybody here in this room, this is I think from about 30,000 feet maybe from Google Maps. It's just my estimation of how high this is. If I'd asked you what this was, I think someone would be able to tell me what that is. Anyone? Yell it out. Golden Gate Bridge. Okay. So here, what is that? Anyone? I'd be very impressed. Yes?
That's the bay.
No, this is the Eiffel Tower. So it's just this idea that, when things are very familiar to us as doctors, we don't necessarily need the most advanced test. We don't need, we already have tools that are good enough to be able, by our eye, to be able to tell where we're at and where we're trying to go. But there are some things, and I think allergy fits into that, where, our tests are pretty crude. But if we had a better way to be able to just zoom in, we'd be able to know a little bit better where we're at. And once we're there, then we might be able to define where to intervene and how to intervene. So that's really the goal of biomarkers. And so in more kind of a sense of why biomarkers are so important in allergy and why we need to define them are because everything works in tandem. So if food allergy is going to be really cured by something like food oral immunotherapy, the reason that it's not ready for prime time is because the reaction risks are so high. We don't know who's going to do well necessarily. We don't know who's going to be successful with the therapy. We don't know who could stop therapy and eat peanuts or drink milk just like we all do, which is to eat it as ad lib. Freely and not every day as you would take a medicine. And so the idea of biomarkers and why we need to do this for allergy is because we'd be able to define the risks for things like oral immunotherapy, figure out who's going to be successful at the therapy and who's not, and also, of course, target our therapies accordingly. And so that brings us to the end, which is that I think as we think about where food allergies will go in the future, this immediate type of food allergy, that is the anaphylaxis, the IgE-mediated mast cell caused disease, I think we're, your kids or other relatives who may have food allergies, I think we very well may have safe treatments to allow kids who are allergic to be able to eat those foods. It'll take a lot of work on the part of the patient, but I think that that's something that for those who are motivated is an option that will be available. And we may even, through things like the food, the herbal formulas, or through work on the microbiome and understanding what bacteria may be protective in terms of allergy, we may be able to have primary prevention strategies as well. And this delayed type, that is things like asthma or eczema, that can sometimes be associated with food, especially eczema. This nut will be a bit harder to crack. And I think that this is where we need to better understand those basic aspects, that network of cells, how different immune cells interact to drive allergy. Okay? And so again, how will we get there? And UCSF, I think we will be, we really hope to be a major player in this. And right now, in terms of this basic science, we have a very strong presence in this. And a lot of investigators here at UCSF are helping to define these networks, understand how allergy is driven, and I think that from that, we'll be able to find new therapeutic targets. But also, we're starting some initiatives here on biomarkers, and this is just what's called a microarray, and it's a pictorial representation of a way where we might be able to find signatures of people who would be allergic or who would respond well to therapy or not respond well to therapy. And so with the clinical goal, eventually, we're not here at UCSF, we're not quite there yet, but I'm hoping that we're going to be able to change that within the next year or two, be able to start even considering seeing how we can make a clinical benefit for kids. So it's all three of these pieces here at UCSF. We've got this, we're building this, and eventually we'll get here as well. And I think that we have potentially a really nice group of folks who can help to really push this along. So here are some references, and so I'm open to questions, and thank you for your attention. So it's free form. We have a lot of time, and but just fire away. Yes. So the question was why I didn't list any eye reactions. I didn't really intend this talk today to be about specific clinical manifestations of allergy. Certainly, though you could see on that picture of that child, you get a lot of angioedema, meaning swelling of the eyelids, and you can get redness. There can be a very profound reaction of the eye called chemosis, where the jelly of the eye essentially swells so much that it comes out, and that can be incredibly scary for folks who see that. This is a little tough one, but basically the question boils down to trying to I'm going to paraphrase, but trying to minimize medication and maximize benefit, and finding ways in allergy to do that. So I think the way I'd approach that is this, that it kind of comes back to, and again, I talked so much about the clinical manifestations last year, I didn't want to do that here. But I think that the dichotomy that I put forth last year was this idea that there's different kinds of allergic reactions. There's acute reactions, the dangerous ones, the ones that are caused when you eat a peanut and have anaphylaxis as its most extreme form. And there are more chronic forms, like eczema is a great example for young children. And so I think for things like anaphylaxis, I don't think anyone would, for one moment, deny the fact that you need medicines now, and you'll use those injectables, you'll use your epinephrine, you'll use your albuterol, you use all manner necessary because it's so life-threatening. In terms of the dermatitis, that's a question that I get a lot, and I think that eczema is a great example of the question that you're bringing up. May not have been one that you were thinking, but it's a great example because it really brings home this idea of using things like steroids versus elimination diets. And I would say this, that the immune system is highly complicated. And the problem is that it reacts to lots of things in the environment. And it's very rare, at least in those chronic allergic conditions, especially eczema, that you're going to find that one food. You may, but in my experience, it's been less often. So I do help families try to find those, try to find that elimination to see if there's a food that might be the one to get rid of. But in the end, usually the best thing to do is to just treat the symptoms, heal that skin, and then move forward from that. Unfortunately, you have to use the medicines, but the medicines work really well. In general, there's very few side effects. I'd say that the side effects of scratching at night and having an unrepaired, having a chronic rash, they can have a profound effect on a child's development. And so it's always, everything we do in medicine is risks and benefits. And I'd love to tell you that, we could find that one thing, but it doesn't always work that way. So the question is a great one. It's asked, the audience member asked whether the reason that we see increased prevalence in developed countries is simply because we're looking for it, we can recognize it, and you wouldn't really see that in the developing world. And while there is, of course, an element of that's true, it's amazing in really highly parasitized areas, you just don't see asthma. And amazingly, other markers of disease. I talked a little bit about biomarkers. We do have some biomarkers of allergic disease. And their biomarkers are off the charts for allergy. But boy, they have none of the clinical manifestations of allergy. It would seem that by living in those areas and having the exposures that they do, they've garnered all the benefits of that allergic immune response, but none of the downside. And we don't fully understand why that is. But so I think that there's an element of truth to your question, but I think in general there's something clearly protective. Or maybe we can put it the other way, that there's something that we're missing. I won't say harmful, but something missing or different about the society that we live in that predisposes us to allergy. In terms of ethnicity, allergy in the United States affects all ethnicities, but especially asthma in particular can really affect the inner city profoundly. And I think there are a lot of really wonderful investigators around the country who are helping to define the allergens that are driving that. So we don't know if it's cause or effect or a little bit of both, just because of the demographics. But it's interesting. So the question essentially boiled down to, why are we being so hesitant in enacting therapies like oral immunotherapy that could be quite beneficial? Well, I'll say that in the initial studies, and this was excluding patients who've had anaphylaxis, at least I believe a third to a half required epinephrine injections along the way of that therapy. So I didn't talk about that, but clearly they had severe allergic reactions. So what I think your point is well taken. And I think that it comes down to two issues, which is number one, we got to diagnose it correctly at the beginning. There are probably a lot of, so the questioner works in the San Francisco Unified School District and has been in schools for 2 decades and has had a lot of experience with different children with food allergies. And so, and she's never seen a reaction. And so I think what comes down to the fact is that I don't know that all of those children that are labeled as such have actually had an accurate diagnosis. And so again, that's what I talked about last year. And then, so that's one piece. So is the diagnosis even correct? And then the second piece is that you bring up the point of why we need these biomarkers. And we might not be able to find them, but boy, if we could, run a blood test and say, you know what, your chance of having a severe allergic reaction is 99% or it's 1%. That's what we need. I don't necessarily want, because the only way to really make a food allergy diagnosis is actually to feed the child the food. I'm going to tell you, I'm not willing to take that risk for someone who, a mother comes and tells me, you know what, my young boy had peanut butter for the first time, lips swelled, he started to make this funny noise where, he was kind of gurgling, or his cry was really hoarse and weak. I'm not sure I'm going to want to confirm that with an actual test. But we need ways to be able to make the diagnosis correctly at the beginning and follow it over time. Things do change. Although for peanut, most kids don't outgrow it, there are some kids who do. So who are those kids? What signatures do they show to tell us that they're outgrowing that food allergy, and that's kind of where we want to go. That's a great question. So the first part of the question was, how does oral immunotherapy work? And I'm just going to say we have no idea. There's a lot of studies, people trying to understand how it modulates and recruits different parts of the immune system. There's a part of the immune system that puts the brakes on the rest of the immune system. And so for, again, not trying to get too technical, there are a lot of folks who think that that's the key. It may be that we convert the kind of antibody you make. I talked a little bit about IgE. Well, that's not the main antibody you make. You make this thing called IgG usually. When you get vaccinated, for instance, or you have a cold, your body makes that antibody to try to fight off that virus. And so it may be that the body somehow, through route of exposure, through other unknown factors, converts that response to a more productive one. That was the first part of your question. The second part of your question, basically, a lot of food labels tell you about trace amounts of foods that are found in, potentially contaminated. And basically, could that be a way to do immunotherapy? What's clear is that you need a lot more than that. A lot of that food labeling is it's my own perspective. It's not necessarily as a physician, but just my own perspective of looking at these things. I think it's a lot more to do for legal reasons rather than to really give guidance to families. Because in the end, it really just drives confusion. Am I really allergic if I can handle this? It says trace amounts. Well, it says may contain. So there's a lot of confusion. So we know a few things. Number one, dose is important. There are some kids who are that sensitive, but that's thankfully very, very rare. Most kids will require they'll need to cross some threshold. Often it's not very much, but they'll cross some threshold before they react. But what's clear from the oral immunotherapy studies is that you need to eat a lot of peanuts in order to gain the therapeutic effect. That's not enough. So the next question is about age of onset of allergies. And in general, it does seem that the younger the child is, there seems to be a higher prevalence to generate de novo allergies. And as the kids age up, they can still get allergies, absolutely. But it seems that essentially, for reasons that are not entirely clear, is that the way the immune system is quote unquote maturing. We use these kinds of very loosey-goosey words, but there may be actually even some scientific merit to these ideas. And I'm not saying there is some scientific merit to this idea that your immune system's changing, and it's probably during those first 3 years of life that there's really some dynamic changes that can either prevent or promote allergy. And so when you get older, probably your chances are less. But there can always be some confluence of factors that either send you back to your being younger, at least immunologically, that drive allergy. Because I don't know if some of your students may have generated de novo allergies, but they definitely can happen. The question is whether adults can benefit from immunotherapy, and if so, whether they could just take a little bit of peanut butter every day to overcome their own food allergy. So the answer to the first part is yes, adults can benefit from oral immunotherapy. The second part I'd say is you want to do it very judiciously. Again, this is not a therapy that is being used clinically. It's only in a research-based setting right now. So it's not something, people can look up these sorts of protocols and whatnot, and I suppose they could try them themselves. I would never advocate for that, just because the reaction risk is high. But anecdotally, it's very funny. A mentor of mine, who essentially was an allergist before there was allergy. His father, this would be in the, trying to get the dates right, it's probably be in the, 1920s, 1930s, found that whenever he'd drink milk, he'd get what was clearly IgE-mediated allergic reaction, classic allergic reaction. And so he, on his own, devised this method where he would drink small amounts of milk so that eventually he could eat some ice cream, and then he'd backslide and he'd start all over again. But again, I just tell that anecdotally just to say that, this has been around for a long time, and I'm sure there's a lot of other stories of people who just experimented with this on their own. But I think what we're seeing when we do the clinical trials is that some people can have very severe reactions, and got to be real careful. So the question is a little afield of what we're talking about today, which is gluten-free diets and the proliferation of them and their potential effects on a very wide swath of diseases. So, I'll simply say this, that I think that, as an immunologist, as a physician, I would say that, you need to study those in depth. And I don't think that those are questions, and I won't say any specific diseases, but there are a number of conditions where you could potentially study it, but I'm not sure that people will, because I think the bottom line is this, we have to make choices. And so long for a child, as a pediatrician, so long as a child, for me, as long as that child's well-being in terms of nutrition is being adequately met, and eventually, hopefully, as the child can make their own decisions, if they strongly feel that they, feel a certain way when they're on this diet versus that, I think that's one's perception of the world they live in, and I think, but so long as you don't extend that to the point where you say, oh, I have an allergy or this or that I do take issue with, because I think it's important that as an allergist that we are very clear on what an allergy is. It serves no one well if we pull in different manifestations that are often not that are not as clear and demonstrable and studied to define them as allergy, because I think that when we do that, then we lose track of what the disease is, and when we do that, then it becomes much harder to attack it. So the question is about obesity and allergy rates, and I think that this is an area that is really hotly studied. I will say that right now, I think that while for a long time people had said, oh, obesity and allergy, they've gone hand in hand in terms of their rise. And so therefore, many people hypothesize a causal relationship, especially in asthma. Again, there's a lot of good data for asthma. I'm not quite as certain anymore. It'll be, but partly I think that we have to let the epidemiology play out, but also the basic science. Partly I'm a basic scientist, and so I see certain studies, and the lab that I work in, we work on various aspects of allergic immunity, and so it sort of clouds my view of the field. But I think that the jury is actually, I think, still out. But you're absolutely right. Those two, asthma, food allergy, and obesity, have risen hand in hand. I'm seeing more and more that maybe obesity levels have leveled off a little bit, and so we'll see if that levels off or goes down, and yet food allergy continues to rise. But then, even then, we've also instituted these new guidelines. So there's all these things that are changing, and so it just shows you the difficulty in really being able to get a handle on all these things. So first, the question is, how do you make a biomarker? And I think that the bottom line is that, for instance, the approach that we're taking is start with a hypothesis that we could do a better job of defining a certain aspect of allergy right now, and employ new technologies to essentially drill down deeper. So if right now we have a 30,000-foot view of what antibody molecules are causing problems, can we get a little bit closer and, again, find subsets or signatures that if you react to this part of the peanut or that part, you're better off or you're worse off, those sorts of things. And so it requires a lot of new technology and investment, and so those are the things that we're thinking about. And so the second question is, what are some take-home points? I think the take-home points are this, and again, I think that last year's lecture probably would be more helpful for that piece, because I think as an allergist, the take-home points to parents are these. I think first and foremost is that we really are not, we really don't understand allergy nearly as much as we hope to, and I think that is both disheartening, but also heartening, because there's a lot of areas that we can address. And I think areas, because it's such a common disease, we actually can make a potentially really big difference in a lot of children's lives. And although it may not be for this generation, I think as maybe your children's children, maybe we'll be able to really have some insightful recommendations that we'll be able to make. So I think in terms of, if we take it piece by piece, a newborn baby, I think in terms of food introduction, I think it would be really, I think it's useful to ask your pediatrician about the new guidelines. Tell them about your family history, and try to work together on a really coherent plan that both parties can agree on. It's being a good way forward to not so much prevent allergy, but I think introduce foods that are integral to your family and your culture. To me, that's what food's all about. It's really about coming together as family and enjoying those foods that either we just enjoy because that's our current tradition, or sometimes it goes back much further than that, and it goes back to the roots of who we are, and I think that's really important. So that to me is what I recommend to families, is that you don't need to say I need to put in peanut or I need to put in tree nuts. It's more you need to put in a diet that makes sense for you and your family, so that they'll be able to enjoy those foods. You'll be able to enjoy those foods together. School-age children who might already have allergy, and it's tough. I think that the most important piece is that we make sure that the allergic conditions are correctly diagnosed. I spend just as much time proving allergy wrong as I do proving that there is an allergy in my clinic. So I think finding a doctor who can work with you on that. Allergies are very powerful. They can have very strong and severe effects on children's health, but we need to make sure that things are accurately diagnosed, and I think that's one really important piece. Adolescents. So adolescents with food allergy. I'm not going to talk about adolescents without food allergy. Adolescents with food allergy. I think the most important thing is to remind adolescents that, especially if they've had a severe reaction, that if they continue and their doctor thinks that they continue to have potential to have a severe reaction, they need to be prepared. It's a time of your life where there can be a lot of pressure to eat a lot of different foods and to potentially minimize the severity of one's own health condition. And so because of that, it's very important that they stick by their guns, and especially if they have lots of reactions, and know that they do, that they carry emergency medicines, or at least tell their friends that they have potential to have a bad outcome if they were to eat these specific foods, and not be afraid to engage medical services. Adolescents often have some of them. They have potentially worse outcomes because they don't carry their EpiPens and because they minimize their symptoms. And so that'd be my message for that age group. Luckily, food allergies are becoming more and more prevalent. So I think that the stigma that may have been associated with them in the past, I've not been around long enough in this field to know what the stigma was 15, 20 years ago. But at least today, I'd like to think that the stigma is less. Certainly, you've seen, since you work in school districts, the amount of attention and the amount of work that's put on to making sure that kids are kept safe. So I think that's carrying forward, I'd like to think. So what's the likelihood that a child will have an allergy if their parent has an allergy? So you inherit the predisposition to an allergy, you don't inherit the allergy. So it simply means that, yes, you are unfortunately more likely to have allergies if your parents did as well. But it doesn't mean that you're going to have their same profile of sensitivities. That's an interesting question. So the question is whether or not a patient, if they have relatively benign reactions, wouldn't undergo a formal evaluation. I'd say no. I mean, I think that if your friend sought out an allergist or physician, they get a workup, and I think that they might be able to find an answer. It might not be an allergy, And in fact, I don't think it's an allergy. But I think that they could get some useful information potentially. So thank you all very much for coming, and I'm happy to stick around for just a little bit if you'd like. Thank you.